Thank you all for joining us today for this Chrome lecture series. And today perhaps will be the last of the daily meetings. I think we're going to try to host a couple more next week, and we'll make some announcements about that. I'm Alan Banks. I work with Road Dental Laboratory. I'm going to introduce the presenter here in just a minute. But I want to mention a few things. Most of our courses are viewable on the CE page of our website, roaddentallab.com, and you'll see the CE page on the right-hand side, second level, and they're all listed in there for everyone to watch. In this series, we presented nearly all of the workflow of completing a Chrome case, from patient marketing to records to components of Chrome, the restorative protocols, the final options. Really kind of went through a lot of the process. But interestingly, we really haven't covered the surgery very much, and that'll be a big part of today's program. But I want to mention that every day I and a few others QC Chrome cases as they leave the laboratory, and I always marvel at the simplicity of the Chrome surgical package. There's just 5 simple components: the pin guide, the fixation base, the osteotomy guide, the carrier guide, and the temporary prosthetic. 5 simple tools, and the sequence and the ease of use really is, I think, unparalleled in the industry, mostly because of the floating guide technology and the ability to just deliver that metal fixation base without removing teeth first or without bone reduction first. That's really the key to the Chrome system. That's not to say that Chrome is the process is simple, or that Chrome surgery is simple. It does take a skilled team to complete, which is why we invited Dr. Adam Folick to present the full workflow today, with a focus on the surgery. Dr. Folick has completed more than 140 Chrome cases. He's accomplished this with a fairly large team that travels between his 4 office locations, while he maintains really a pretty full teaching schedule around the country. So please allow me to introduce Dr. Folick. He's a graduate of Temple School of Dentistry in '97, AEGD University of Mississippi Dental School, Georgia Maxi course since 2002, private practice since 1998. He's the director of the Chicago Maxi course, actually, which I've had the privilege of working alongside him for hands-on courses there and in Vegas. Very good courses. He's also a diplomat of the ABO-VIID and an honored fellow of the AAID and past president. And he's served in various aspects of leadership in AAID for about 14 years. And he's a KOL for us and for MIS implants. And on a personal note, after working with Dr. Folick through many full arch cases and through all types of challenging dental work, really developed a high respect for his knowledge and abilities. And with that, I'd like to introduce Dr. Folick to take over the show. Thank you.
Thank you, Alan. I want to thank everybody who's online today, and I hope that I'll be able to make things interesting. If you were on last week, I went through the staff workflow and what we do in our office to help make sure that the staff is on board. We showed a case kind of from a little bit of the surgery. We didn't go in depth in the surgery and how we do things. Today, I'm going to go through the patient entering all the way to the final delivery, with a concentration on what we do with every patient, and how we're able to work the patients up. And the way I'm going to go through this is also how I teach in our Maxi course our doctors who are getting ready to take the associate fellow exam or the diplomat exam, what they need to be doing, how they need to be looking at the patients, and the kind of questions they can expect to be asked, because you're expected to be at the highest level of your game when you're doing this within implant dentistry. I want to say, first of all, this is the holiday season. I want to extend a well wishes to anybody who is celebrating Passover, and also Good Friday. A happy Good Friday to those out there celebrating Easter, and I hope everyone has a wonderful Easter weekend. So Alan was kind enough to go over my bio. This is a picture of me if you haven't seen me before. Obviously, if you've seen me before, this looks like it's been photoshopped. So this is the best I think I've ever looked in my life. All right. So we're going to talk of a case presentation of a single patient coming in and how we work up the patient. And when we have a patient coming in, we have it at their initial appointment. This patient, she comes in and her main concerns are appearance, longevity, and maintenance. And that's something that we have to find out. Not just, I don't like the way my teeth look. We actually have them go into a little bit of depth to find out what their main concerns are now and for the future. We ask them questions about their appearance, about what's the most importance is longevity, being able to take care of it, not having to have a lot of parts and pieces that she's always having to deal with, or restorations that she feels like she's always having to deal with. So these are her main concerns. We gave her a list of things to go down. She's already been to another office for a consult and was given a treatment option of an all-on-4. We don't have clear choice down here. There is one in Washington, D.C. I'm in the Virginia Beach, Norfolk area. There's one about 3 hours away in D.C. There is an office that's kind of done their own version of clear choice, and they advertise as such. And she went there and was given the all-on-4 option. The cost was more than she expected, and was interested in a second opinion and treatment options. And in fact, she had gone searching the all-on-4 because at her previous dental office, she had just, she was tired of the issues that she was having with her existing restorations and them failing, and just never feeling that she could get ahead in her life with her dental treatment. And she was in the process of this appointment of quitting smoking. So this is our patient here. She's a 62-year-old woman. Her medical history is that she's type 2 non-insulin dependent diabetes mellitus. She has depression. She has been diagnosed with tonsillitis. She does not. She never had surgery for it and was told that surgery was not necessary, but they do inflame and get irritated every so often. She has hyperlipidemia. She has had shingles on the right side of her torso, her upper torso in the past. And as far as previous surgeries, she had a laparoscopy 40 years ago to treat endometriosis. And in 2006, she had a hysterectomy, and she was treated for a bowel obstruction, all in one surgery. Her medications. She's taking metformin, 1,000 milligrams twice a day. Not the extended release, obviously. She is on Lipitor, 10 milligram once a day. Aspirin, 81 milligrams once a day. She was taking Chantix at her initial appointment when she came to see us in the attempt to quit smoking. And she takes a multivitamin. So let's talk about these medications and the importance of understanding these medications. From her medical history and the medications, we have to ask a few questions. So with metformin, we have to take into consideration a few things. First of all, we want to know what her A1C is. If we're going to do any surgery on her, we want her A1C to be below a certain level. It depends on your confidence, whether you want it to be below 7, 7.5, or below 8, that depending on the surgeon and what they're doing with that situation. You as the doctor have to make that diagnosis for yourself and feel confident going forward. And there's some other things that we have to be careful with metformin. We also know the patient is, as a diabetic, is going to have she's not going to heal as well as other patients. So we have to take that in consideration. We have to be careful that her post-op nutrition-wise, that we give her the right instructions. And with our patients if we decide to do a full arch case or even an overdenture, they're not able to eat correctly, we want to make sure that they are maintaining their proper nutrition, and they're maintaining they're testing their glucose on a daily level, as well as checking their A1C as they need to be. And we also need to know that long-term metformin can cause a vitamin B12 deficiency. And with that, you can have a burning taste in your tongue or a sore tongue. So you need to know that ahead of time and let the patient know that could be a problem so that they don't think there's something that you've done in that situation. And we also need to know that with the metformin that they can, there is a rare case of actually having angioedema. And if the patient does, if the patient does have some sort of facial tongue swelling, that this is actually a medical emergency and they have to be treated as such going to the hospital. That's a very rare case, but it's just something that we have to know and keep in the back of our mind. As far as aspirin, 81 milligrams, in my practice, that's not worth changing the dosage of. I leave the patient on it for all the surgeries. A multivitamin, we want to be careful that with a multivitamin, the patient is not taking any sort of fish oil or omega-3s, which could cause prolonged bleeding, especially since she's on the aspirin as well. All right. With the Lipitor, any of the statin drugs, I mean, there's not much that we have to worry about, but maybe an interaction with erythromycin. If we decide to do that, we don't really prescribe erythromycin in our practice anymore, though. And at the initial appointment, we're going to go in and make sure that we understand the patient's concerns. Now, we talked about what she wants. Now we have to understand her concerns. She's not happy with the appearance of her teeth. She has lost faith with her current dentist and the fact that her restorations are constantly failing. She consistently gets diagnosed with decay at every appointment. She feels like she cannot get forward at all. She cannot move forward, and she would like to change the color of her teeth. And she lacks confidence with her smile. So this is our patient. This is what she looks like when she's smiling. This is her profile. We're going to take a look, and we ask the patient to smile. Now, I have my assistants take a lot of pictures along the way. So we asked her to really smile big for us. And if we see her smile big, we can actually see more gingiva in place here. So that's a nice big smile. We know with a lot of our restorations, once we change the appearance, we see that lip line move up a little bit more and becomes a little bit more hyper, exposing a little bit more of the tissue once they have more confidence with their smile. So we need to take that into consideration when we're designing our prosthetics. Here we go with her teeth in occlusion. So what I wanted to show you with these next three pictures is it's very interesting. I'm looking through the pictures that the staff took, that my team has taken. You can see that the patient is kind of biting on the tongue and it's protruding into the edentulous spaces. She might not be biting on it, but it's protruding into the edentulous spaces. And we know that the tongue can get larger with missing teeth, especially on the lower there in the back, in the posterior. But I want you to take a look at the space between number 7 and number 27. We date to our next picture. It's a little bit wider of a space now that she has here. The tongue is not being compressed by her teeth or not filling in the void there. And finally, this last picture actually shows the patient in the maximum intercuspation position. So this is actually the picture that we need to take into consideration. It's important when you're not taking the pictures, and believe me, I've had plenty of pictures that just look absolutely horrific, and you wonder how anyone can take pictures on cameras nowadays where you can actually see what they look like. But this picture really shows us where the patient is going when she is fully occluding. So this is the picture that we can use here. We're going to take a look at the incisal edges of the teeth. Are we happy with that, with the way they're lining up? We take a look at the midline. Is the midline correct? Do we want to straighten that up? And how can we straighten that up? We're going to look for all sorts of different diagnoses in our intraoral exam. This is the look over at the right side of the mouth. Take a look over here. A little bit different position over here on the right side. And we're going to take a look over here on the left side of the mouth. We're going to take a look at the palatal position of the palatal view. And we're going to take a look of the mandibular view. And here is her FMX. We can take a look at what the teeth look like. We can see how much decay is visible. We can see the bone levels. You know, I'm a huge believer that every patient that gets an implant needs a CBCT. I think it's the standard of care. I think it's been documented that it's the standard of care. The oral maxillofacial radiologist wrote a position paper stating that, and I think we all need to be doing that with our implant placement. However, I feel that PAs and bite wings are essential in my diagnosis and treatment planning of patients that have any teeth in their mouth. It really gives us a good idea of what's going on with the surrounding bone and any decay, because we really can't see that as accurately on a CBCT. A CBCT is great for planning, it's great for seeing pathology, but it's not really what we use when we're just making these initial diagnoses. So you want to take a look here. And then we can start to do our dental diagnosis. So just extraorally, I just wanted to let you know there was no TMJ pathology. We checked the interauditory meatus. We checked the pressure against the TMJ on opening and closing. We palpated the muscles of mastication, the masseter. We checked inside for the temporal, the pterygoid muscles, the lateral and medial pterygoid muscles. Then we put pressure against the temporalis. We put pressure of the patient's mandible on loading, and there was no issues, no fremitus, no signs of popping or clicking within her joints, and no pain to palpation of any of those areas that I mentioned. She has a class 1 occlusion. She has rotation and crowding of her dentition. She has a narrow arch form on the palate, which would be important for our treatment planning. She has a palatal torus and lingual exostosis. There's missing teeth. We saw decay. A lot of decay was prevalent throughout her mouth. We saw some fractured teeth. We saw fracture lines in her teeth. Saw fraction and recession, occlusal wear, and super eruption on the left-hand side. Now that super eruption wasn't just of the teeth, it was of the soft tissue and the bone itself, which will be important. And if we go back and taking a look at that patient, let me see if I can go back to this picture for just a second here. We can see that soft tissue has come down with the bone over here. So that's going to affect where we decide to reposition those teeth and how we decide to reposition those teeth with the treatment planning. She has a type 2 periodontal disease. It's never been diagnosed, or if it was diagnosed, she's never been in for periodontal therapy. She had a type 1 mobility on her lower anterior teeth. She had a nice thick gingival biotype, which works to our advantage for any surgery that we're going to be doing and for the aesthetics that we're going to be taking into consideration. She has overall healthy gingiva. Even with everything going on, if you remember taking a look, she's very cognizant that she takes care of her teeth. And that's one of her big complaints, is that she's always taking care of her teeth. There wasn't hardly any plaque buildup at all, but there's no calculus on the FMX, but she just feels that she's always getting decay. She does have a high lip line that's going to affect where our transition line is going to be, and we have to take that into consideration when we're deciding what to do. So again, I wanted to take a look over here where we're taking a look at the transition line. Now, I've mentioned in the past that there is something called chrome natural out that we've been starting to do, and maybe she might have been a case on the top for doing that. At the time of this was done a few years ago, and I wanted to present a case that we had done about 2-3 years ago, because I want the patient to be in full function and operating as such, so that you know that the success of this case has moved forward. I don't think it's a good idea to show a case from beginning to end that has not been into full function. So this is a case where the chrome natural might work on the upper, so I'm not going to mention that. We have to think about our dental diagnosis now. What are we going to tell the patient? What are we going to, how are we going to work through this? We're also going to take a look at the CBCT, and we saw a pneumatization of the sinus, especially over on the right-hand side. I'll show you that in a little bit. She is a Kennedy class 1 on the mandible and a class 3 on the maxilla. She has division A bone at the edentulous sites of number 7, 20, and 29. She has division B bone in the posterior molar region of the mandible. and she is a Siebert Class 1 classification. So if we take a look over here, I'm going to push play here. We can see her CBCT that we took, and we're going to go along. If you take a look at the bottom left-hand side, you can see the cross sections as we're going across the arch of all the top and the bottom together. And she seems to have enough width and height for us to do what we need to do if we wanted to keep the teeth or take the teeth out. We're going to go and take a look all the way around. At the very beginning, you could see she had she had some bone on the right-hand side where the number 3 tooth was missing. But the nice thing is that she seems to have plenty of bone within her mouth for us to do implants if we are to go forward with a full arch case here. We're just moving and scrolling through to make sure that you can see the upper and lower at the same time. Even where the foramen is, it seems to be enough space. So as far as looking at our division bone right here at the area where the foramen is and the second bicuspid would be on this picture, we can see that she has about just over 6 millimeters across the bone in width there, and about 12 millimeters from the lowest aspect of where the mental foramen is. And we could easily fit an implant in there, and this is what's going to give us our division 1B bone here. This actually could be division A bone at this point in time, but she has enough width there for that number with anything over 5 millimeters. On the if we go posterior to that on the right-hand side, this is where we have our division B bone right here. She's at 3.35 millimeters, so that's going to put us division B, but she has enough height there. On the left-hand side, again, we have the division A bone around the foramen area, over 5 millimeters and over 10 millimeters in height. And then if we go posterior, we're less than 5 millimeters, we're at 3.7, and again, 13 millimeters in height in the posterior on the left-hand side. We take a look up top on the upper and number 3, we have 7 millimeters in length in height before we get to the sinus. And if you take a look over the other side, you can see the bone has dropped down. And even though there might be enough space, once we remove that tooth, if we decide to remove that tooth and we remove the bone, there's not going to be nearly as much space to put an implant there as we're trying to create the teeth that are going to go there, and we have to take that into consideration. And I try to leave, if we can, 15 millimeters of space in the interarch when we're doing from the crest of the bone to the incisal edges. If we take a look at the number 10 site, the missing tooth, we can see that there's plenty of height there, and the width we have at just over 5 millimeters. Plenty to place a single implant if she decides that's what she wants to do. So our treatment plan options. Now this is where it gets complicated. Just think about what we saw there. There's so many things going on within her mouth, and I'm going to go back to the picture one more time here in the anterior. There's so many things we can do. We saw that she had, look how healthy her gingiva is. So that works in our favor. She definitely takes care of her mouth. That's something that works out well. The super eruption, as we mentioned, is going to be an issue. Her issue, though, is decay. So we still have to go over all the different treatment options that are available for her. And this is where it gets confusing for the patient. And so, you know, we're going to mention that she needs periodontal therapy, and she's going to have endodontics with crown and bridge work, orthodontics to push the teeth up, to intrude the teeth on the left-hand side, or some sort of crown lengthening with the endodontics, and then a lower partial. That's one option. No, again, we're talking the same. The second option is pretty much the same as the above, except that maybe we place posterior implants and bridges on the mandible. Okay, maybe we're going to do a little bit. We can extract the teeth of the lower anterior and do a bridge from the 22 to 27, and we can place some implants in the posterior and do some bridges in the posterior. Then there we can add on to that. Maybe we're going to sit there and. Maybe we're going to sit there and add implants in the posterior mandible and implants on the upper teeth. Now we're going to place some implants instead of just doing crown and bridges on the upper. Maybe we're going to do implants in the number 3 and 10 area with a subcrestal sinus augmentation, and implants in the anterior and the posterior mandible with bridges on those teeth. We could do periodontal therapy with endo and crowns, full arch with implants and abutment crowns on 3 and 10. Again, the subcrestal augmentation, and this time full lower extractions and 4 implants with an overdenture. Maybe just remove all the teeth and keeping the maxilla in with crowns and full crowns, and so that she can take care of it and maintain her smile because she has more teeth on the top there. Or we can do that same option as above, and instead of an overdenture, do 4 to 6 implants with an all-on-4 on the lower. It says gold lower, but it should say full lower extractions. We could also do the same as above, and instead this time we're going to do full lower extractions and place about 6 to 8 implants with bridges. Just try to create an FP1 situation. We could do full mouth extractions with immediate and then traditional dentures with tori removal. You do full mouth extractions with 4 to 6 implants and overdentures on the upper and lower with tori removal. We can do full mouth extractions and all-on-4 restorations on both arches. And finally, we could try to do full mouth extractions and about 8 implants with abutments and bridges on full on the upper and the lower, and trying to create an FP1 instead of the FP3 situation that we would have with the all-on-X. So just think about that. We just went through a slew of treatment options, and we're supposed, as you know, obviously doing nothing is always an option that we're supposed to give, but the patients come to us, especially for a second opinion. They don't want to hear do nothing. They want to hear what to do. Then they're going to rely, after they, even if you were to give them all of these options, which we're supposed to give them all the options, it's way too complicated. I think it's way too complicated for our staff to keep up with. So it's really up to us to decide what's the best thing. And I try to go over with my patients and simplify what's going on. The nice thing is that she's already told myself and the staff, I don't want to have any more crowns or restorations on my teeth. She's looking to have her teeth extracted just because of the amount of decay and all the decay that's present. So we can automatically eliminate that, but we do have to tell her that getting her teeth replaced with root canals and crowns and bridges are an option for her. If she did want to try to keep them, we have a lot of things to go through. Then we have to sit there and try to determine, try to explain to her the difference between an overdenture and what an all-on-X situation would be versus an FP1 restoration. And so you have to have pictures, and you have to be able to tell the patients what this is going to look like and give them the options and the pros and cons for all of these. And we do a very good job, and I think we have models and we have pictures that go through everything. And then price is going to be a factor as well. So with her, she came in, she listened to everything we had to say. I don't think we were much different in our approach to everything. She was excited to hear about the overdenture situation, and then we just didn't hear back from her for about 6 months. And then she came into our office and said she was ready to go. She'd gotten her funds together, and she wanted to go forth with the all-on-X scenario. She thought that would be the best for her. We did let her know that she would have to have a certain amount of bone removed to do that. She was okay with that. She wanted to go forth, and she thought she'd be able to take care of it. We went over all the steps for taking care of it and what that was going to involve and her responsibility with this. So I went through this in great detail at the last webinar last week. So I'll just quickly go through. We took digital scans at that point. We took a new CBCT. It had been 6 months. Nothing had changed. We have to then upload the CBCT, the intraoral scans and photos to Row and fill out the treatment plan. We had our online consult. We confirmed the surgery date. We had to order all the implants, the parts and pieces that were necessary for the pickup of everything. And then we bring the patient in for the pre-op. We have to do a check of physician release. We always get the physicians to approve the surgery that's going to be done and to go over any medications that the patient might be missing or anything in their medical history. We do all of this under IV sedation. I am IV sedate. I do have my license for IV sedation. I do bring in a anesthesiologist to do all of my work, though. It just makes it much easier for me, and it takes a lot of the stress of the situation off for me. And then we have to check the guide, the initial guide, to make sure that plastic guide fits over the patient's teeth and that we don't have any issues with that at that appointment. So here's a picture of what we have. This is the guides for the top teeth and what we're going to be looking at. We'll go over that in a little bit more detail now. These are the models for the upper and the lower, the stereolithographic models that get sent back in the box from Rowe. And these are the plastic guides that go over the teeth that will go into the bone reduction guide and allow us to fixate that into place correctly. And these are the models of what it's going to look like on the maxilla and the mandible. I love these models. I think they're very important. They show me how much bone I'm going to have to reduce here. Sometimes we have to reduce more bone in the posterior than we do in the anterior. And if you remember over there on that left-hand side, that's exactly what we're going to do. So we're going to have to, you know, this is sitting down. So you have to look the right-hand side of your screen as the left-hand side of her mouth. You can see how that's raised up higher. And we're going to have to reduce more bone. And we're going to get closer to the sinus. We have to realize that also. And I like to see, take the bone apart to see what it looks like. We have a look of our mandible over here, same sort of thing. We're going to have some reduction, and most of that reduction is just due to the thin bone around the extraction sites in the anterior section that we'll see. Then we have to make sure that we reduce the bone back properly and create this sort of look in the mouth. All right, so now this was done a couple of years ago, 2 or 3 years ago, so everything is improved much more so. If you take a look at the bone reduction guide, they now have those blue plungers which go in much easier. Didn't have these, even though they worked well, they were quite stiff. For all of these cases, I use, we have those big, heavy temporary remover pliers that they look like hemostat, but with a thick, wide end. I use those to pull the plungers in and out. Makes it a little bit easier trying to get back there than with my fingers all the time. And they're still a tight fit, which we want them to be a tight fit. This is the bone reduction guide for the maxilla. If you take a look, there's a hex. But that hex is no longer there. That's for the timing of the implant to make sure we have it in the right position. Now there is a rectangular protuberance that will let you know exactly how to line the implant up when you have to angle your implant and use multi-units of the 17 or 30-degree multi-units. Here, everything is fixated into place. We want to make sure that the plungers are pressed in all the way, that we don't have any issues. You can see on the maxilla, if you take a look, on the right-hand side, we got the guide is going to be a little bit higher because we're going to actually do a subcrestal lift and use a mallet to push that up. Here again, we have the guide for the lower. And we take a look at the plastic guide for the prosthetics. We can see where we're going to need to have our multi-units here for the lower. And we also have the rapid guides that the rapid and the PMMA that we're going to be using for our patients here. And here we go. Sorry, this is for the lower. I apologize. And this is going to be the lower PMMA and the rapid. I like using the rapid. It does take a little bit more time. It really doesn't take much more time. It makes it, I think the lab likes the rapid a little bit better than scanning in the scan bodies. We do both of them depending on the situation, but I think this gives them a very good verification. For the maxilla, I always have a backup denture. I just think it's necessary. There's been 2 or 3 cases where I've needed it, and it saved me. It's really saved me in the past. So just pay the little extra and order that. If you never need it, that's fine. I don't worry about it on the mandible because usually I've never had an issue with the bone on the mandible. You're just going to have D1 or D2 bone, but it is important to look at your CBCT. And if you see a lot of medullary bone on the mandible, you don't see much, it's all grafted, and maybe there's no cortical bone there, you might want to have a lower backup. All right. So this is the plastic guide in place. We make sure it fits again. The patient, this is back when we were doing betadine. Now we're using Paradex rinses, and we're going to start going around with our scalpel blade, and then we're going to start reflecting the tissue. As we reflect the tissue, we're moving it up, and we're going to have to move it up enough so that we can get the bone fixation guide into place and place our anchor pins. We want to release it. It's a full thickness flap here. We can see some recession of the bone on the canines. We can see how deep down they have fractions go here. Now we're going to put that guide back in position, this time with the bone reduction guide into place. And then we're going to use our anchor pins to fixate that. We're using the short anchor pins we have. Now, I am placing MIS implants. As was mentioned before, I am a KOL for MIS, and but I still use the older hyoscine pins when I fixate this into place. I have used hyoscine in the past. It's also a very good system. Both of these systems are a keyless system, which I like. So now we've got everything into place. The tissue is retracted. We can really see everything nicely. You can see all the recession there where we're missing bone over on the left-hand side. And we're going to start extracting the teeth. And once the teeth are extracted, take a look at the scalp edges. And we can see there's very little bone reduction that's going to occur over on the maxilla here. And at this point, I don't remove the palatal tissue until this point, and then we go ahead and I will reflect the palatal tissue and tie it off there so that I can do my bone reduction. And then I'm going to take a round burr. You can take a football burr, but a carbide. I always have at least a couple there. They do clog up and they do start to get a little bit dull, so always have a backup there so that you can go through with this. And you can see the irrigation going here, and it's just important to be able to the whole thing that I love about this system is the visualization of everything that we're doing here. So we're going to start to smooth out the bone. As you can see, we're starting to flatten that out. We're going to use the buccal aspect of this as a guide for that. And what I'll sometimes do in these situations afterwards, I'll come in with a file and just smooth it out a little bit more to make it nice for placement here. And then we go ahead and place our osteotomy guide in place on the maxilla. Now, if you take a look on the right-hand side, it's on the left-hand side of your screen, the right side of the patient, though, that the osteotomy guide for that is actually in a lower or higher position, whatever your frame of reference is, than the other osteotomy guides. And that's because we were mentioning it being about 7 millimeters. So if I want to place a 10 millimeter into place there, I have to have them position that 3 millimeters occlusally from the other osteotomy guide so that I get to the base of the sinus, and then I can subcrestally lift that with whatever system, whether you want to use the Versa system, whether you want to use a osteotome system, or even some sort of like the CAS or the Neobiotech system where it's raising it and using irrigation to lift up the membrane and then place your implant with some bone. With the MIS system, there is a starter drill that goes into each of the sites here. And as you can see, there's no keys, one size for all, as the barrel of the drills are the same for every length and width of the implants, which makes it nice. And then we're going to be placing our implants. I am placing it this time as the C1 implant, which is a conical connection. I'm going to put that into position and place that throughout the maxilla. And then we're going to place our prosthetic carrier guide over onto the bone reduction guide. You can see the implants through that. I always look through the holes and make sure that we have enough space to put our multi-units at this point and the cylinders. If you need to, you can go ahead and take it out and make the holes a little wider. That's, you know, I've done that several times. There might not be, you know, things are not 100% perfect. There's always, with any of these, whether it's static guide or dynamic guide, there's about at least a 0.5% accuracy with everything. And and sometimes the bone's soft and the implants might migrate just slightly. Maybe your angle's off. So, or maybe there's a situation that caused it to be that way. So you can widen these, but take it out the mouth to widen. Otherwise, you're going to have plastic going everywhere inside the patient's mouth. Then we'll place our multi-units. These are the straight abutments on the anterior. As you can see, we have angled abutments, multi-unit abutments in the posterior. We can see on the left-hand side, you know, due to the angulation sometimes, or where you're positioning your implants, or the extraction site that you're putting it in, because we put it in the crestal bone around that number 3 site. We're going to be grafting there, so we will graft around the threads. We're going to come back in. We'll put our multi-units into place. You can see a little bit on the number, I guess, 11 spot or 10 spot, around the number 9 and 8 spot. I made those a little bit wider to make sure that we had enough space for the base of the cylinders there. It's not going to affect anything. And then we place the rubber dam materials that's provided by Rowe over these. This will stop the the quick up material or the Voco material, whatever you're using, the taub, from getting in there and attaching to the implant itself, the multi-unit or the MUA, and causing it so that you can't remove it. So we have these wonderful stoppers that Roe is providing. We're going to make sure that you put the stoppers in after you put the PMMA, so don't put the stoppers in right away. Put your PMMA into place. Make any enlarge in any of the circles if you need to, internally and externally. You can't just do it on one side. You have to do it on the intaglio surface and on the surface with the gingiva and the teeth are. And then we place our stoppers into place. We put the pickup material around there, the luting material, and then we take it out. And I always go and I try to see if these have any movement to it. If there's any movement, don't play a guessing game. Put everything back into place. The ones that are fixated, that's good. Go ahead, reposition the other one, add some more material, and get that so you get a nice passive fit. This is very important, especially during the healing phase, okay? And it's going to be important for how we process and go forward with making sure everything's correctly positioned. So you can see I got my finger there, and I'm going ahead and I'm going to move those, see if I got any movement at all on these cylinders. And then I'm going to place the rapid into place. You can see the rapid here. We're going to pick it up. Again, it's going through the same process. This is the final coming back, and we're going to send this. This is the other side of the final before I send it back. My assistant's going to do all this work, filling in the circle, filling in the voids on both sides of the PMMA. I'm not worried about filling in the voids for the rapid as much, maybe just a little bit if it's a large void, but as long as there's no movement, that's what we're going to use to transition and send back to Roe. Now here's some bone with some PRP in it. This is autologous, it's allograft bone that we're using. It's a mixture of, it's a 50-50 mixture of cancellous cortical. We're going to place this around the extraction sites or any of the threads that we might have seen around the extraction sites, and put our comfort caps into place. And then we're going to start to place some PRF that we have. She didn't have very large pieces of PRF, but no matter what, I found that the PRF in place and any membranes that we decided to do has, especially the PRF though, has really made our healing time so much better, and the patient's experience. We usually get patients coming back with very little issues within the first week, and they're very excited about it. And I really attribute that to the PRF and how that works with the healing. And then we're going to start to suture everything up. Now, I'm not going to deliver the PMMA at this time, even though we could have. It was ready by the time I was finished. Why am I not going to deliver it? Because I'd rather have a lot of room to work. If I have the PMMA in place and I go to work on the bottom, then it's going to get in the way of me trying to take the teeth out and do all that work. So if I don't have any teeth on the opposing arch, it's much easier. You know, when we are working on just one arch and there's teeth, sometimes it can get in the way, especially when we're getting the posterior and trying to angle our implant placement. So again, we're going to do the same thing. We're going to go ahead with our 15 blade, reflect the tissue back here. I'm not going to go into as much depth. You can see all the length of the decay there going down her teeth. And we're going to position, we have our bone fixation guide into place here. We take the teeth out. And while we are taking quite a bit of bone in the anterior, if you take a look at it, it's all that very thin scallop bone. And by the time we remove all that, we're really just at the level of where we need to be just to have a flat surface to place our implants. And it would be very difficult in the posterior where she's missing some height in the proper positioning. If we wanted to place the implants for a FP1, if we wanted to place them more buccally, we'd have to expand that posterior ridge. It's still lower than the plane where we are right now with the teeth once they've been extracted. So we'll tie back the tissue there, and then we'll go ahead and start to reduce the bone on the lower. See the tissue tied back there. Take it down a little bit more, and then we've got our osteotomy guide into place. You can see we have the angled implants in the kind of the first bicuspid area, maybe even the canine area. But I love the fact that I'm able to get implants in the posterior there. So we're doing, again, the same protocol that we do when we're doing our implant placement, our starter drill, and then we're placing our implants. You can see we've got the osteotomy guide into place. And we had an issue with one of the implants when we put it in. It did not torque down as well as I wanted to. I got it to about less than 20 newtons. I want my implants, I Ideally, at that time, we weren't doing ISQ. We are doing ISQ for all our implants. But I have my motor set at 35 to see if it can torque out. And usually what I want to happen is that I can place the last few threads of the implant with a wrench, because with my torque wrench, because it torqued out when I was placing it with the motor and the drill itself. We were not able to do that though on the left-hand side. When we placed it, the bone was just too thin. Even though we have denser bone in the mandible, when we're removing some of the bone, we remove that cortical layer. Sometimes it can be a lot of soft medullary cancellous bone there that we're not able to get that tight D2 bone and that fixation at the that we expect to have when we have that cortical bone there. So in this situation, we did not include that posterior implant with the PMMA, and we put the rubber dams into place. We got the comfort cats. You can see I've got a little abutment that comes with the implant still in place there. We're eventually going to put a cover screw over the top of that. We got our lowers now sutured up in place. But we did put the multi-unit on that lower implant, and we're going to be able to use that later on if we want, or when we want, excuse me. Now we've got that all in place. We've got that removed. And now we have the patient as she's coming out of surgery. So as I said, we do IV sedation for all of our patients. We actually are doing nasal intubation. So it's very difficult to get a good occlusal scheme on some of these patients as they're coming out. Sometimes we can get them, we can reduce enough, and then there's times that we just can't reduce too much as the patients are coming out. So we bring the patients back within the next few days to come back and reduce their occlusion. So this is a few days later. She comes back. You can see she has some stretching from the lips. She has some sore spots where her lips were cracking. We do place vitamin E on their lips throughout the procedure. And this is what she's looking like just a few days later. You can see the roof of her mouth, the soft tissue that looks tremendous. And I really equate this to the PRF and what that does for the healing. Now we can see that she has way too much occlusion, especially on that left-hand side. And so we're gonna grind her into occlusion. She's in some discomfort here, so we're gonna do as much as possible, but she's being very diligent about not putting any pressure against her teeth when she's not eating anything solid. We put them on a liquid diet for 8 weeks. All of our patients understand how important it is, and we've been very lucky that I think I've only had one patient not follow those directions. And we've been they really do understand. But this is what she looked like when she came back in. So we're going to reduce her occlusion. And this is what she looked like about a week later. About another week later, we brought her back. You can see on the left-hand side, I've reduced that occlusion. To be honest, I probably could have or should have cut the posterior aspect back on the left-hand side of the bicuspids. But we decided just to leave it there. I trusted that she was going to follow directions, and she did. And there is no occlusion against that lower molar. So we adjusted the occlusion one more time because now she was feeling a little bit more comfortable. She was able to open her mouth so her lips weren't cracking. And this is what she looked like when she came in about 3 to 4 months later for us to do the rapid impressions that we're going to take. So you can see she's now occluding a lot better. She's a little bit more of an edge to edge that we're going to correct, and we're going to send these pictures to Roe and show. And listen, we want to create more of a class 1 occlusion in the anterior. You can see in the posterior she's not occluding at all. We can take a look over here on the right-hand side, and over here on the left-hand side, we reduced it so that she doesn't place any pressure over there. That's what she looked like. So we were using some sort of temporary material at the time. We've changed it. We've gone back and forth on all this. 2 of them have popped out, but she's keeping everything clean. And that's one of the things we noticed, she's able to keep it clean. So over on this time, we had, I mentioned a cover screw. I think we had just done we exposed the implant and then placed the multi-unit back into place. This was easy as a straight multi-unit, so I didn't have to worry about positioning an angled multi-unit. You see there's some pressure around where that denture was sitting against the tissue. And what I did is I just took the cylinder and put the cylinder in place, and I placed some rubber dam material around it. We made a hole through I didn't do a good job of getting a picture of it. We made a hole through the rapid in the posterior, picked that up, and then had her, and then did the same thing as we've normally done, placed some quick up material around it. And then once that was done, we screwed in the upper opposing, and we were able to get the rapid position and showing exactly what it looked like once we ground the rapid into occlusion. So when we did grind the rapid into occlusion, you can see there's no post, it's not touching on the left-hand side of her mouth here. So we're going to send all this back to Ro and tell them what we want changed and how we want it changed. Probably reduce a little bit of the overjet in the posterior on the right-hand side, and obviously we want the teeth to be in contact on the left-hand side. And we want to lower the gingival margins a little bit and make the teeth a little bit longer. Okay, they did a nice job here with the midline. This is what she looks like with everything retracted back. You can see her tissue is looking fairly good here. This is where she's looking. She's giving somewhat of a smile, but we can at least see where she is when she pulls her lips apart. This is a little bit more than repose here. She's overall fairly is happy with the way things look. So this is, sorry about the blurriness of this. We've sent that off. We did take an impression. I didn't show, have a picture of that where we added some light body against the intaglio surface. Dr. Yates showed that last week or this week, I forget. And we sent it back, and this is the try-in phase that we have, the printed try-in phase. And we can see we have the occlusion is looking better. She now has a nice type 1 occlusion in place. She's got a little bit more rounder teeth, which she wanted, which we asked for. And we're going to ask them to maybe move the teeth up a little bit more on the left-hand side, and if we can, try to show a little bit less gingiva. Now, one of the things we do show the patient, if you look, the left-hand side of her lip is slightly higher than the right-hand side. So she's going to show more gingiva there. And you have to show the patients this, that this is nothing that we can control for lip positioning. But this is everything in place. We take these pictures and we send them back to Ro. We want to make the teeth a little bit higher on the lower mandible so that we can get a little bit better contact. But overall, we like where everything's hitting. We'll show them this, the dots that we're getting there that we've after we drilled in the occlusion a little bit more or adjusted it slightly. And I think actually at this point we might have also done a, you can see the tissue here. We have done a impression of the intaglio surface one more time. Now when bringing her back, we can take a look. Her tissue is good. She's got a little bit of irritation down there, but we're going to change that with the final design of the final prosthetic. One of her biggest concerns was she thought I thought it looked great, but she thought the tissue on the PMMA was a little bit too red. She wanted a little bit lighter pink, so we changed that up for her. You can see the teeth are a little bit more round, a little bit softer for her. This is exactly what she wanted. We're doing the trilore here. I like the trilore, especially when I have it opposing arches. I feel that I have less clacking sounds and clicking sounds that the patients complain to me about. If it does break or fracture, it's easier to repair. You can't repair the zirconia. And for our patients, they're very happy with the aesthetics of it. And you can take a look here. She's very happy with her smile. I'm going to take a look one more time coming from the different aspects. And then, sorry about the green screen. My assistants were trying out something new, which we're not doing anymore. But this is her smile. She's extremely pleased with how it looks, much more aesthetic from where she started out. If we take a look at the final CBCT here, you can see the implants in place on the maxilla. Taking a look at that axial view up there, everything is looking nicely where the implants are placed. This is probably about a year, let's see, not a year, sorry. This is after we placed the implants here, probably about 6 to 8 months later. You can see some of the bone that we've added over on that left-hand side. And if we take a look down here on the bottom left-hand side, you can see the implants in place on both sides, the angulation here for some of them. I'm going to push that implant up on the towards the sinus over there. And now we're taking a look at the anterior implants on the top and the bottom. We can see them together. They're in the bone very nicely. And we're coming down here. We can see the implants in place on the right-hand side. Slightly push that up there. Okay, so that is, well, we're going to take a look at the lower, excuse me, the lower one more time. So you can see the axial view there. It's a little bit longer of a CBCT. I wanted to make sure everyone got a good view. Let's see. And you can see also over there on the right-hand side, you can see the top where you push the sinus up a little bit, add some bone at the same time. And that implant that we placed on the number 3, we were able to get a torque of, I think it was at least 50 newtons when we were hand torquing it into place there. I undersized all my maxillary osteotomies by at least one, depending on the softness of the bone, sometimes even two. I want to really be able to hand torque that into place and get over 35 newtons when I'm placing my implants. So I want to thank everyone very much. I want to thank you. I hope everyone stays safe. I want to wish happy holidays to everyone, whatever you celebrate. If you don't celebrate anything, happy April, happy spring. And Alan, do you have some questions for me?
I do. Thank you very much for that thorough presentation. That's start to finish. That's terrific. Thank you for that. We have some questions. One is from Dr. Alexander is Trilor frame, not teeth, right? And that's correct. The substructure on that final that Dr. Folick showed is a Trilor sub, and then Crystal Ultra teeth, and the two are bonded together. And that's also available in a titanium substructure with crystal teeth on top.
That is correct. It's the Ultra Crystal on top of that. That is correct.
Yeah. That's one of the three main options. We also do full zirconia. Here's a question for Doctor. Have you had patients complain about extra tissue on the palate?
No, not really. Maybe after the first week or so, but I've just noticed, like I said, with the PRF, and now what we're doing is I'm getting the PRF and I'm taking a little tissue punch and placing them around the implants. We're really not noticing that. Now I do cut the extra keratinized tissue on the palate and scallop it around the implants themselves in the multi-units, because we have plenty of keratinized tissue. That's really the only place I feel that you can do that. I don't do that on the buccal, even with a gingival biotype like what she has. But again, I don't feel, I have no issues with doing that on the palate. So we try to reduce that extra palatal tissue. I'm sorry, I'm connected to my office at the same time, and apparently that's the little doorbell ring when you're with EagleSoft. So I apologize if y'all are hearing that. But no, we don't usually have issues with extra palatal tissue there. Because of that, we really go in and sometimes remove quite a bit of that.
Here's a question, just a little follow-up on that. How often do you have to repair this kind of appliance? How stable is the color? This is still too fairly new for me to give you an accurate answer. I think that Alan's going to be much better at telling you the stability. We've been very lucky, knock on something, wood, whatever, that we haven't had any issues right now. I think that, if we do, you can repair it. I think the important thing is you can repair it quickly and get another one made, because they keep these on file for, I think, 10 years, Alan? Is that how long? Yes.
So the fact that you can keep this in the patient's mouth and get them to fabricate a new one for you, to me, is extremely important. So otherwise, with the zirconia, you're kind of screwed, to be honest. Where it fractures, you have to take the other part out. There's no way to lute them together.
I can add to that. We have a few thousand of that particular restoration in mouths walking around, and that goes back just a few years. It's like long-term studies hardly exist anymore because they come out with material so quickly. We had several issues with the combination of crystal and Trilor at the very beginning, a couple years ago, and even into some last year. Don't really want to pick on the company too much, but there is a design factor of the substrate. It has to be supportive, like everything else in dentistry. The substructure has to support the superstructure. It's got to be designed right. We had been instructed incorrectly for a while. We are making a very nice crystal ultra material on tie or Trilor now. We've really gotten over the hump of issues. So I would not hesitate to order that if you have enough space. This is not for the case that has 10 millimeters, 9 millimeters, 12 millimeters. It really should be 13, 14, 15 millimeters. You have a good amount of material for both the substructure and the teeth, and then you can have long-term success. But and then doctor, maybe you could help me on this. It really may come down to patient selection. If a patient has just a history ruining their restorations. They're overclosed. They're destroyed everything. That's their patient history. They should probably be in zirconia over zirconia.
Yeah, I mean that becomes it becomes an issue. You know, I'll take the other thing that's helped me out in a lot of these situations, I think, and I have nothing to base this off of, just based off of the amount of failures that we've had with the materials, is that I try to place my implants as posterior as possible, and I reduce the cantilever space tremendously. I try not to go I don't go 1.5 times. I might go 1 time posterior, but if you take a look, I was able to get the implants in the molar regions, and I try at almost every aspect to do that. And even with the angled implants on the lower, if you don't have that space available, I'll just tell the patients they're only going to get so far back, and that's the best that we can do without doing tremendous sorts of like nerve repositioning procedures that I just don't want to do anymore. So the patients have to understand their anatomy plays a part in this, and we have to reduce the amount of cantilever we have, and I think that helps out tremendously. You know, even with patients who have bruxism, zirconia can break. So, you know, those patients that are bruxers have huge masseter muscles. They can. We've had patients that break implants. So, you know, if we create enough, if there's enough space inclusively, you have enough VDO to have that Trilor material, and I'm a big fan of it. I think it's going to wear better. And if it wears out quickly, there's nothing, you just have to tell the patient that there's most likely it's going to wear out quickly. I know some people love zirconia, and I do a lot of zirconia crowns and bridges. But I just had so many issues with zirconia against zirconia, which is complaining of the clacking and the sound. I think it looks beautiful, though. I really do. The zirconia nowadays is amazing. So it's just dependent on, you know, your patients might be great with zirconia, you might not have any issues. And again, we might have less issues with zirconia, but if something's going to wear or break to me with Trilor and everything's equal, then there's a possibility it might do that with zirconia. Not as great, but it's still good. So
the other part of the question was color stability and aesthetic, you know, over the long haul. And I think that's, you know, again, how long have these been in the mouth? You know, composites are very stable. This is a light cured composite material that we used for the aesthetic part of it. I think that a patient just has to go through regular hygiene. I think the hygienist has to be careful of what materials they're using, their pastes, to make sure that they're not gritty, make sure that they have these latest pastes that don't take stains and composites off and have things have a surface that's rough. I think that part's important. We have some of these cases come back, you know, with issues that have been in the mouth for 3 years, and some of them look very good. Some of them look used, as if the patient has not gone to their hygiene check. So I think that part's really important. What is your go-to implant system? That's from Dr. Ken Palladino, actually a local doctor, a friend of ours. What is
my go-to is the MIS. I was with them for a few years, but they years back when they first started, their prosthetic components weren't anywhere near where they are now. Like I said, I am a KOL for MIS, but the reason I like it is the design. They have a V3 implant, which is even more aggressive than the C1, and I think it's wonderful surface technology around it. But I find it easy to place, and for guided surgery, the system is ridiculously easy. I don't have to worry about spoons or sleeves or keys. So for me, that is it's a wonderful system, and I love the conical connection, to be honest. So all those things together seem to work out really well for me. Like I said, I have used Hyosin. I think it's a good system. I like the fact that I have various platform widths that I can use, though. That's the one disadvantage of that system. But overall, that's a great system, as is Neodent. All the systems out there are good. I've used BioHorizons to have great success with BioHorizons as well, too.
Trilor would be better bond to nano versus titanium, as it's a chemical bond, whereas titanium has no bonding and higher chance of fracture, but parafunction, etc. Titanium would allow for more stress, dispensation, and implant protection. So that's from Dr. Alexander. The nice thing about titanium is it's more rigid, right? And that might support the Trilor better. Both both substructures are designed fairly similarly in our software. Both are designed for prosthetic support, for material support. I would agree that if we had to, if it was insisted that we make a long cantilever longer than our rules, you would want to do titanium for sure. But probably between the two, I don't know that there's really an advantage one over the other. If you have teeth that's delaminating off of titanium, it is probably a process issue. The material was not adequately put between the two. The substructure was not perfectly designed for it, or usually when there's a problem with these cases, it's a shearing, which means that teeth could have been going in the, cantilevered over the metal, extended, buccally, that type of thing. So usually it's a design issue if it's one or the other that are failing. Do we have any other questions? I don't think so. I think that's all. That's all the questions. And one more note on that is we don't bond the crystal material directly to the titanium substructure. There's always an opaque baked layer in there. That's important. So
I saw there's a question from Akil. What's my average time for these dual arches?
I love that question.
All right. So I schedule 3 hours per arch, and then an hour recovery time for sedation. We hope to be done between 2 and 2.5 hours in arch, though, unless there's an issue that occurs that we have to deal with. But really don't go much over 3 hours an arch.
Yeah, and I think that sometimes you'll see some boasting on the internet, or perhaps salespeople or so forth talking about times. We never want to consider this a speed race, but usually we suggest 3 to 4 hours for your first arch, several arches. Block that time out, and then after that you start to work your way down to this 2.5 hour time. I've seen some quicker, but depending on what kind of situation it is too, how much bone reduction, how many implants, that type of thing.
Yeah, and obviously the extracting of the teeth, sometimes some are a little tighter than others. I said, let me see this other one. Adam, given that the last implant went at 20, it's actually under 20 newtons. Would you still load it now knowing that you're cross arch? No, I don't. It's just a comfort thing for me. I don't load any implant that's under 25 newtons for sure. I try to get them at 35. So in a situation like what I did, we've had very good success just coming back and later adding it to the appliance. And the thing is, I had a case, and this is something that Alan would probably appreciate. I had a case, would appreciate as far as asking our doctors to do. I had a case on the maxilla where nothing went in over 20. And I understand the theories behind cross-arch stabilization, but I've also had implants fail when loading them up, and I just don't like them to fail. So we grafted around them. I placed the multi-units in place and did the PMMA and the rapid, and then took everything off, at least for the straight abutments. And I was able to go in at a later period of time and put the multi-units back into place, but everything was already indexed. So it made it much easier at that point in time. And I don't know if that's what y'all suggest, Alan. It made it much simpler. I've done it before where everything was covered and I placed the PMMA back into place, but then you don't have the distance that's created by that carrier guide. So you're slightly off and you might have to change the VDO slightly.
Well, we love that technique. We advocate it on any time you're not going to deliver, and you still have the ability to maybe not torque, but hand tighten in the abutments and the temporary cylinders and loot them to the prosthetic, because you will not have a second chance to orient that prosthetic correctly according to those implants. Anything subsequent to that surgery is going to be a floating technique, which is never advised. So even if you're only indexing 2 implants on a 6 implant case, you can still come back later and pick up the other 4 cylinders and send it off to the lab, or let the patient wear it. The indexing is the key. So, yeah. And even if even if the time is running out and you still want to pick up the rapid appliance, but but time's running out. Still, if you can pick it up on 2 or pick it up on 3 to tripod it, take it back out of the mouth and hold on to it, then the rapid is also indexed. It's a huge time saver in the future. Jen has a question for you, which is just one of our Chrome doctor's assistants. Thanks, Jen. Is that do you always do double arch same day, or do you sometimes delay the second arch?
If I can, I try to do the same day. I want to reduce the amount of surgery time for the patient. I think that's beneficial. Having to come back, and it's also easier to get them to line up. If there's any issues, we can deal with it all together. The only time I've ever had an issue dealing with was a patient that was severely immunocompromised, and we knew we could only have the patient under for so long. And but otherwise, we try to do double arches the same time. And I'll tell you this, could we do it and see other patients in the afternoon? Absolutely. But I know if we're lucky enough to get a double arch, you know what? Be happy with it. Take the rest of the day off. Enjoy yourself. Go outside. We get the chance now. There's a silver lining in everything. So the silver lining in this whole thing about staying at home is we get a chance to kind of be with our family and get a little bit of relaxation. I don't feel like I get a lot of that. So when I get a case like that where I get a double arch, if I'm done 2 hours early, I leave. I don't have anything else put on the schedule. My staff knows that. And you know what? Pat ourselves on the back. We had a good day that day.
Love it. Dr. Folek, that is the end of the questions. I want to thank you again for presenting this. Very grateful. And for anyone listening, if you want to share this particular video with anyone, it will be up. Probably it'll be sometime on Monday. Probably this one won't be on there today, but it'll be on our website starting Monday. So thanks a ton. If there's no more questions, we'll say adieu, and everyone have a wonderful weekend.
All right. Thank you, everybody. I appreciate everyone being on board, and have a great holiday.